Good evening, ladies and gentlemen, and welcome to tonight's Global Wound Care Today Facebook Live, entitled Are Incisions the Forgotten Wound? Rethink Incision Care to Improve Patient Outcomes. And our fantastic speakers who are with me now are Dr. Daniel Chaverri Fierro.
Good evening.
Are you both well?
Yes, I'm well.
I'm hoping the weather is slightly better with you than it is here.
Sorry, here in Lisbon it's raining. It's not a good weather.
Same weather here in Spain.
I shouldn't be happy and relieved. Part of me is, so I apologize. Ladies and gentlemen, as you can see, our speakers are delivering tonight's session from home. So if we have any technology problems, please bear with us, and I promise you we'll have them sorted out as soon as possible. The link for the certificate of attendance will be made available towards the end of tonight's event. That counts towards your CPD, your revalidation. So please wait for that to appear. All the slides and also downloads for the resources, which we'll talk about later, will be made available after the event on our website, which is woundcare-today.com. As I'm sure Sara and Daniel will agree, the more involved you are, the better it is for the event. So let us know where you're watching from, and please ask any questions on the chat function, and we'll endeavour to answer as many as possible before the end of tonight's event. Before I start, just a massive thank you to tonight's global partners who are Mölnlycke. Without your commitment, your passion for independent and modern education, these events simply could not and would not happen. So a massive thank you from me and the team. So without further ado, it gives me great pleasure to introduce tonight's first speaker. Over to you, Daniel.
Okay, thank you. I don't know if you can see my slides right now. Yes? Okay. Well, thank you, and hello, everybody. It's a pleasure for me to be here today in this great event and to share with you my experience and knowledge in the as an orthopedic and trauma surgeon in the field of the surgical wound care. Well, during this event, we will try to answer this question. And this is a question that Sara Carvalhal and I did ourselves several months ago. And answering this question, we elaborate this document that is still in press. And the final conclusion of this document is that if we have to improve our outcomes, we have to rethink the incision care. So I will talk you about my experience as ortho and trauma surgeon, and Sara, after me, will talk about her experience in oncology surgical wound care. So to rethink, let us start with some interesting data. First one, we know that the higher risk of outside-in surgical site infection is within the first 4 days after surgery. We know that the wound complications are rare to appear in the first 7 days after surgery. And also we know that the dehiscence appears between day 7, day 13 after surgery. So with this important and key data, I would like to ask you this question. Should the dressing be changed routinely every 24, 48 hours? Makes sense to do this? And the answer is negative. It makes no sense, as we will see. Well, let me show you our surgical non-complicated wound care protocol. As you can see in the slide, we start the surgical wound care in the surgery room, and we try to do only 2 or 3 dressing changes in the whole healing process. 2 days after surgery, before hospital discharge, we check this dressing and we decide if it needs or not a change. And that depends on the bleeding and if this dressing is saturated or not. We will talk about it later. Well, the best moment to start the surgical wound care is in this moment, in the surgery room. because here we have an ideal environment, we have sterile conditions, and it's the best moment to cover the wound and to isolate it from external agents. If we want to reduce bleeding through the wound, it's extremely important the way that you close the wound, and if you achieve or not a good hemostasia. One thing I try to do is work without ischemia in my surgeries, because if you work without ischemia, you can see the bleeding and you can coagulate, do an accurate coagulation of these blood vessels. Every time I finish a surgery, I do this thing before I apply the dressing. I squeeze the wound in order to get out the blood that is below the skin. This is important for the dressing durability and to prevent the seroma or hematoma formation. And don't forget to dry all around the wound in order to allow a good fixation of that dressing. Well, this is the situation in the vast majority of surgical procedures 48 hours after surgery. The dressings normally are clean with no bleeding. But sometimes we have these situations. What happened with this bleeding? The question is, when do I have to change this dressing? Well, we do it when the bleeding reaches 2 or 3 edges of the dressing. If the dressing is like in the picture on the left, we maintain the dressing in place. And if it's like in the picture on the right, we remove it and we change it. But look at this case. This picture was taken 7 days after a patella fracture surgery. The bleeding, as you can see, saturates and overflows the dressing. And you can think that this is a dramatic situation. You can guess that the wound is in bad condition. But let me show you how is the wound when we remove the dressing, we clean the wound, and we see that the wound is almost in perfect condition. It's in a pretty good conditions. So the message is that we have to trust in these advanced dressings. These dressings manage perfectly this challenging situation. Let me show you another example. This is a patient with an open ankle fracture, surgically treated first with an external fixation, and then with open reduction and internal fixation using a double approach. We didn't use ischemia. We achieved a good hemostasia. And these are the wounds, the anterior wound approach. And this is the the wound of the lateral approach. And we can see to the traumatic wound in the hindfoot. All of these wounds were covered with an advanced dressing in the surgery room. And this is the follow-up 7 days after. We can see that the dressings are partially saturated with blood, but like in the case that we could see previously, we will see that the wound is in pretty good conditions after 7 days surgery. Don't forget to do this, squeeze the wound. This helps us preventing these hematomas or seromas. And this is the condition of the wounds with no clinical sign of infection, no maceration, no dehiscence. So this is a really good outcome, 7 days after surgery with only one dressing covering the wound. This picture was taken 20 days after, when we removed the sutures, and the wounds are completely and normally healed. But till now, we are talking about of non-complicated wounds, but you know that every day we have to deal with challenging situations like surgeries in elderly patients, revision surgeries, periprosthetic fractures, and I'm sure that you agree with me that all of them are risk procedures and challenging procedures. But fortunately, we have new tools, and for that, we have new perspectives to manage these situations. And one example of these new tools are the negative pressure devices. But the question is, where and when I have to use these negative pressure devices? The evidence recommends us to use them in two situations, in revision surgeries, or in two scenarios, in revision surgeries and in patients at risk or with risk patients. But this is the big question. What is a risk patient? Today we have tools. We have tools like this that I use in my daily practice that help me in the decision making. This tool have major and minor criteria and a final score, but I repeat that this tool help me in the decision making because it's a non-validated tool. So the clinical judgment prevails over this risk assessment tools. Mölnlycke is now working in a validated tool that will help us, I think, in the future in this risk assessment. I highly recommend you to read this paper. It's a free paper, and I'm looking forward to the validation of this tool. Well, moving on to this next question, when I use this medical device, this negative pressure therapy? Well, I can use it in two ways, like a prevention or prophylactic way in closed wounds as an incisional therapy in patient at risk, and I can use it for the treatment of open wounds like descents or traumatic wounds. Let me show you some examples of this. First of all, we will focus in prevention. So this is a patient with an ankle fracture history, surgically treated with an internal fixation using a double approach, who had a descent in the anterior approach. That was a hard-to-heal wound. This patient, like almost all of these patients, develop an post-traumatic arthritis. So we have to prepare this patient for an arthrodesis. And first of all, we have to remove the hardware. In this picture, you can see the scar of the previous descents. We consider this scar as a high risk factor, because if in the primary surgery the patient develops a descent, why cannot develop another one in the same site, this second procedure? So for us, this is a high-risk patient, and for that, I will use, in these cases, the negative pressure therapy. Here we are removing the posterior implants. Here we are removing the anterior implant, and we decide to use this therapy prior or before the surgery. And of course, we have to start this therapy, like in the other cases, in the surgery room. Remember, ideal conditions, a sterile environment. This is the better moment to cover the wound and to isolate it from external agents. Well, it's very important to dry all around the wound if we want a good adherence of this dressing. It's very important to seal the dressing with this field transparency dressing in the lateral, in the medial part, and proximal and distally. This is an easy to use device like other ones in the market. It's easy. And finally, when we have completely sealed the dressing, we will have to connect the cannula to the device, as you are watching in the video. You have to press the button during 3 seconds and the device start working. So let's go to see the follow-up of this patient. This is 6 days after surgery. We remove the dressing and we can see that the wound is in good conditions. Remember to do this. I repeat it every time. This allows us to prevent hematomas and seromas. This is the posterior approach with only an advanced dressing. Good conditions of the wound. Remember, wound pressure therapy, 2 weeks, 1 device, 2 dressings. This is 2 weeks after surgery with the wound in pretty good conditions. No complications, no clinical signs of infection. And this is the moment, 3 weeks after surgery, when we remove the sutures and we can see the wound completely healed. And this is 45 days later. No complications, wound scar, and notice that in lower limb we incorporate as a part of the wound treatment the use of compression stockings. With this, we can control the lower limb edema, and that sometimes can cause dehiscence in the wound. So let's move to another challenging clinical case. This is a female, 90 years old, with history of a total knee replacement, diabetes, renal insufficiency, chronic venous insufficiency, who had a septic loosening of these prostheses. You can see in the movie the high instability of this knee. So we have to treat this situation with a 2-stage surgery. First one, removing the implant, cleaning the site, obtaining samples for culture, and putting there a spacer with antibiotic. I'm sure you are aware with me that this is a high-risk patient. So we start negative pressure device in therapy, in the surgery room. This movie was taken only 30 minutes after surgery in the recovery room. We encourage the patient to move the knee or the joint, and these devices allow this to move early. This is extremely important for us orthopedic and trauma surgeons. Notice that we don't use dryness. I don't usually use dryness, radon dryness or something like this. But what happened, this is the follow-up only 7 hours later. Dressing is saturated with blood, canister is filled with, it's full of blood, but the device is still working, and this is important. So in this situation, what we do, and because the device still works, we only change the canister, but the dressing remains in place. You can think that this is a little bit crazy, but not, as you will see in the next slides. This is 7 days after surgery with this saturated dressing, but the device is still working. When we remove this dressing, the surprise is that the wound is in perfect condition. Remember, non-drainage, we don't have hematoma or seroma below the skin. We didn't use dryness. It's a high-risk patient, 19 years old, and you can see that 7 days after surgery, the wound is in good conditions. 2 weeks of this therapy, again, another dressing, is still the same device, and this is 2 weeks more or less after surgery, with the wound normally healed, and this is when we remove the staples. This is a I think it's a very good outcome. Another case, the decision making in this case was taken during the surgery because of soft tissue conditions. This is an ankle fracture, double approach, anterior and posterior, long duration surgery, soft tissue inflammation during surgery, and a high tension closure. This is another high-risk situation to indicate incisional negative pressure therapy. And the decision-making, remember, was taken in the surgery room or in the operating room. So we start this therapy in the surgery room. And like in the previous case, don't worry, this is the situation 1 week after surgery. Don't be afraid if the dressing is saturated. What is important is the device. If the device works, don't worry. This is when we remove the dressing 7 days after, and this is the follow-up, 2 weeks with negative pressure therapy, and this is the follow-up, and we could see that the wound healed perfectly. So let's move to when I use negative pressure therapy to treatment of an open wound, for example, adjacents. This is another challenging situation. A patient with necrosis in the surgical wound who needs debridement, the debridement that we did in the office, and we remove all this necrotic tissue and the wound is clean. We have to fill up this bed with granulation tissue. This is another good indication of these devices. Remember, 2 weeks, 1 device, 2 dressings. And this is the follow-up only in 2 weeks. Notice that when the wound is depth, like in the beginning of the case, 2 centimeters depth, more or less, the use of a foam below the dressing is recommended to fill up the wound. When the granulation tissue grows up, and the foam is not necessary. So we use it in the beginning during 1 week, and then we didn't have to use it anymore. And this is the finally situation with the wound completely healed. And finally, rethinking, we completely agree with this new concept, this shift of paradigm that is the undisturbed wound healing. We have to manipulate the wound only when it's strictly necessary. It's important to maintain a constant temperature in the wound, an optimal moist environment, and mostly keep the wound free of external agents. If we want to achieve a normal wound healing process. Of course, we have new challenges, risk patients, revision surgeries, but fortunately, we have new tools to deal with these situations, like advanced surgical dressings, negative pressure devices, and in the future, risk assessment tools, validated risk assessment tools. And I would like to finish my presentation with a line that I try to follow every day that says something like this. If you have a wound, cure it less, and when you have to do it better. So thank you very much for your attention, and it will be a pleasure in the question time to answer your questions.
It was a pleasure to see your wonderful work with the ortho and trauma patients. Now, I will share my experience in surgical oncology. So I work in a cancer center in Lisboa, Instituto Português de Oncologia, and my main focus is skin cancer, sarcoma, and peritoneal disease. And I'm also a proud member of the wound care team in my hospital. So as you all know, in the oncology setting, the research and the trials are always pursuing improved results for better survival. So we often get advances with systemic therapies like immunotherapy and also targeted therapies in the recent years. Also nowadays in surgery, we can perform more extensive surgeries with less morbidity. We have better technologies, better expertise, and also all the enhanced recovery programs to help patients to suffer less and also recover faster. And we also had the paradigm shift for minimally invasive surgeries and robotic that help us to get enhanced results with less morbidity and a faster return to normal life. So we have all these improvements in surgery, and when it comes to incision care, we still use the same basic dressings to cover our surgical wounds. Is this correct? The wound means so much for the patient. It's like a symbol. And for us, it is also a window reflecting our surgery. So why is still so poorly handled? When we talk about complications, we saw it in Daniel cases. It's always a bad and a very serious result. We saw it in his cases. But when it comes to oncology, a wound complication can have implications in the global treatment plan of the patient. Most of the treatments in oncology are now multidisciplinary. For example, in my sarcoma patients, most of the times after surgery, they will have to start radiotherapy 4 to 6 weeks after. So wounds have to be perfectly healed, and also the peri-wound skin. And on the other hand, for example, in colon cancer, patients have to start chemotherapy 1 month, 1.5 months after surgery. So if we have surgical complications, we can delay the adequate time frame to start the next treatments. Also, we all know complications can have a very negative impact on immune function and overall health, and also in the patient's psychological status. And even more important, we know in oncology that surgical complications can affect the main oncological results that we want the best for our patients, overall survival, and also the risk of recurrences. This can be explained because the complications can induce a pro-inflammatory state, and these can lead to growth and spread of residual cancer cells, and this increase the recurrence. So there is an urgent unmet need that is to incorporate the advanced wound care in the clinical setting in surgical oncology. In fact, in all the surgical patients, as you heard before. There is no reason that these days where hospitals spend so much money in surgical technology, in energy devices, top-notch staplers, and also robotic instruments, and do not pay almost any attention or spend almost any money to deliver better quality incision care to patients. Surgical instruments are used by surgeons to achieve safer and faster surgeries, but they come out of patients as soon as the surgeries end. So dressings stay attached to patients and can impact the quality of life in the immediate post-operative period. So I think that we surgeons must start paying more attention to what kind of dressing do we want to leave in our patients, or maybe start seeing the dressing as a technology too. Our experience with advanced dressings started back in 2020. It was the middle of pandemic. And we selected some patients that had large incisions in anatomically challenging areas, and also patients that had early discharge. We wanted a more absorbent dressing with good adhesion that led to early mobilization of patients. And we wanted the dressing to stay in place for 1 week. So remember, this was the pandemic. the hospitals and the primary care were struggling. So I used this punchline to get the approval to start using these more advanced dressings. With these dressings staying in place for 1 week, I could save hospital or primary care visits. And now I will share 2 cases from this experience. As you can see, we have a patient, a 77-year-old patient with the leiomyosarcoma of the shoulder. And you see here on these pictures, the first 2 pictures are the wound and the dressing in the OR. And the second, the C and D images are the dressing in place at day 6 post-op. You see only a tiny bleeding mark on the dressing, and the wound looks really, really good. And we had a chance to see that the dressing stayed for 1 week perfectly, and also start understanding and getting the feedback from patients that these dressings were more comfortable. The dressing change was completely pain-free, and the patients were really happy that they could shower. Our nurses were also happy because they start trusting these dressings, and they could postpone the patient visits. And this resulted in less overall visits. And I was happy because everyone was happy, and because I saw less complications, and the patients were really, really happy. So after this, I started putting the dressings to test in even more difficult areas, like axillas. And even in this extra warm and moist location, the dressing stood up, as you can see. The picture here, the picture B, shows the dressing at day 6. Sorry. And the dressing, despite some rolling in the upper part, looks really, really good. In this case, even the patient was surprised on how well the dressing stayed in place. And I could continue showing up pictures of all locations possible, because I think I tried almost all locations possible. We now expanding the usage of these advanced dressings to breast cancer patients, to pediatric patients, and also patients with previous history of dressing intolerance of some kind, like blisters or other skin issues. So here are my final remarks. As Daniel already explained, undisturbed wound healing should be our focus instead of any routine care that we use because someone told us to. Dressing changes should be based on clinical needs and not on beliefs or dogmas. And we should use advanced dressings based on patient risk profile, as Daniel already explained. There are a number of tools in the ortho and trauma too, and also starting to appear in the general surgery too. Colorectal patients have already risk assessment tools to use to decide to use advanced dressings and also negative pressure therapies. And I would suggest also know your personal or local unmet needs. For example, for me, it was to reduce the visits in the pandemic time. For you can be other things. It can be to reduce the pain in dressing changes. It can be to reduce the incidence of MARCs and other skin lesions caused by dressings. So to conclude, I believe that using advanced wound dressings and including negative pressure wound therapy dressings, we can achieve cost savings, both in material and clinical nursing time, to achieve faster healing times and get fewer postoperative complications, and most important, to improve the quality of life of our patients. Thank you.
Sara, thank you. Daniel, thank you. And thank you to all of you guys out there for your comments, your kind words, and your loads of questions. Daniel, if you get a chance, have a watch again. There's some very nice things being said, so really appreciate the presentation. There's some fantastic educational links, platforms that will help you with regards to incisional care that should be on the screen now. We're slightly biased about Microworld. Mölnlycke have some incredible stuff through their academy. So they should be on the screen now, but also when we have the section of our website with the video, with the slides. These resources will appear there as well. I think I should probably get on with the questions as we have a few to tackle. Guys, what I'll do is I alternate between you, but then if the other one wants to add anything, please feel free. So Sara, shall I start with you? So question number one, how can we make the surgeons and nurses understand and implement this new concept of undisturbed wound healing?
That's a really good question, and I get that question a lot. So I understand that it's difficult because the way hospitals work, we are used to do things really fast and always the same way. But there is a body of evidence that shows that undisturbed wound healing is the way to treat incision care. I can understand that surgeons want to look at the surgical wound at all the time just to make sure that everything is fine. But as Daniel showed, in the first days post-operative, we don't expect to have infections, and if we explain the evidence and show the guidelines that are regarding to incision care, I think it's possible to convince the surgeons, even the older ones that I know that sometimes are the problem, to start to use this concept of undisturbed wound healing. My experience is that nurses are easiest to get them to embark in this change of practice. Surgeons are more stubborn, so in my practice, I start talking to the nurses first and getting them on board, and slowly I can convince my fellow surgeons to start changing their practice too.
Brilliant, thank you. Daniel, do you have anything to add to that?
Yes, I would like to add that first of all, they have to try, because if you don't try these new tools like surgical dressings, advanced surgical dressings of negative pressure devices, you don't have you don't know how they can manage all these challenging situations. And I think another important thing is to standardize process. I think it's very important to do protocols based on consensus between nurses, between doctors, and work as a team. I think this is extremely important. It's important to create multidisciplinary commissions in the hospitals or in the institutions, groups of work about wound care, and multidisciplinary groups or works. This is important to converge to one direction, that is this shift of paradigm, that is the undisturbed wound healing.
Thank you, Daniel. So the next question for you, how would you best argue, and maybe argue is the right word, how would you best argue with a surgeon that has a protocol involving daily dressing changes? Would you persuade or argue with a surgeon who has a protocol that still involves daily dressing changes?
Well, I think this is Sara told us before that the evidence show us that manipulating less the wound is better for the wound. So I will tell this surgeon the evidence, and it's comfortable for the patient and for the healthcare provider that they don't have to work every day removing this dressing, and it's better for all of us, for the team, for the patient, and for the wound. So
thank you. Sara?
If I could just add, I think a lot of this practice of changing dressings every day comes also because we are used to use very poor dressings that are not well adhered, that are not waterproof. So people don't trust the dressing, so they don't respect it, so they keep changing it, and they don't remember that's not the best thing they do for the wounds. But I think it's really important, this technology and quality issue. It's urgent to use better quality dressings. I don't understand how my colleagues that love to use technology still don't want to use a more technological dressing. And I think if they start seeing the dressing as something valuable, they will respect it more and don't keep touching and changing it all the time.
Thank you.
I think I would like to add one thing more. The surgical wound care starts in the surgery room, but it still starts during the surgical procedure. This is extremely important, and this is something that all surgeons, especially orthopedic surgeons, have to know. A key point for me is to work without ischemia, because if you work without ischemia, you can do a better, accurate hemostasia. So the bleeding, you can reduce the bleeding through the wound. And another way that is important is the way you close the wound. It's very important to do hermetic and homogeneous closures of these wounds. And we used to use barbed sutures. These sutures allow us to do a more homogeneous closure of this wound. And another thing that is important, especially in revision surgeries, when we decide to use negative pressure devices, is that we have to be aware that within the 7-8 hours after surgery, the wound bleeds, and bleeds a lot. So if we use a negative pressure device, the nurse in charge of this patient have to know that she will have to change the canister. And this is really important. It's like a radon drainage that we change when it's filled full of blood. So this is the same thing. I think it's important.
Daniel, thank you.
Remark this.
I think this is a key issue that Daniel is saying. When you start using different or more advanced dressings, you have to make sure that everyone involved in the care of the patient that has that new dressing understands why we are doing this and what to expect and what to do in each kind of situation. This is really important. When I started using advanced dressings, I had some issues with the nurses of the wards. I could not explain to all of them why I was doing this, and I get some issues. They saw the tiny blood marks on the dressings, and they changed it, and it was my fault because I didn't explain and teach them what to expect and what to do in each situation. So this is really important. When you want to implement something like this, you have to make sure you teach and you explain, you convince, you get on board everyone involved, from the nurses in the operating room to the nurses in the ward to the nurses in the outside clinic. So this is really important. You have to really spend some time explaining and teaching why are you doing this.
Yes.
And I think this leads on, immediately to the next question. So Sara, I'll leave this to you. If a patient has had surgery 1 day ago and the dressing has one small spot of blood or no blood stains, but asks the nurse to redo dressings before sending the patient home, what should I do?
No, I never change dressings the next day just because. I never do that. If the dressing is perfectly adhered and has nothing or just a small spots of blood, I explain to the patient, this is normal, this is okay, you don't have to change it. Your wound is sealed since the OR. There's no reason for me to go and see it. I'll see it in a week from now when you come to the outside clinic. And I do this, and the patients understand this and accept this really good. And as I told before, if I explain to the nurse that this is advanced dressing, this is, I want undisturbed wound healing, they all understand and go, okay, now I understand. Let's let the patient go home.
Thank you.
I completely agree with Sara. We have to educate the patients and ourselves that this is normal, and the wound will be in perfect conditions. We can see that in our presentations, and the criteria to change these dressings is only when the bleeding reaches 2 or 3 edges of the dressing. If not, you don't have to change this dressing. You have to trust in the dressing, and for sure the wound will be in perfect condition.
Thank you. We have 2 more questions, and then you guys can get on with your evenings. So for Daniel, for you, do you need a pressure dressing for after surgery?
A pressure when?
After surgery.
After surgery. After surgery, I use these negative pressure devices in revision surgeries and patients at risk. This is the most important thing. But the big question is, who is at risk, or what is a risk patient? So the clinical judgment nowadays is prevails over risk assessment tools. And why? Because these tools are not validated. But we are talking about risk assessment tool for the wound, for all general surgical procedures, because we have validated tools, but only in some specialties and in some particular surgeries. But we don't have a validated tool, a standard validated tool for all surgical procedures. This is something that we have to work. And to answer your question is revision surgeries and patients at risk.
Thank you. Sara?
I'm not sure if the question was negative pressure or compression. I don't know. But
so can I ask you that one about compression as well? Because okay. I agree with you. When I read the question now, I didn't know whether they
I'm not sure. So I will answer the same as Daniel regarding my general surgery, surgical oncology. I use negative pressure therapy in patients that had prior radiotherapy, so are at risk of poor wound healing, and also in emergency surgery like colorectal and reoperations, open operations. As Danielle said, there are a number of tools, of risk tool assessments that are being worked on and will soon be validated. And I think in just a couple of years, it will be well established in which situations you should use negative pressure wound therapy. If the question was about a compression therapy after surgery of the lower limb, I also do surgery in the lower limb. So I do exactly the same as Danielle does it. I use compression therapy, combine or not with negative pressure, because I understood and learned from our experience in other types of wounds that compression therapy can help to control the edema and improve the wound healing in surgical wounds in the lower limb surgery. So I use it exactly as Danielle told us.
Thank you.
Sorry, because I understand another thing, but compression I do in the same thing that I use in the same thing that use Sara in lower limb especially, because in these situations the edema in the lower limb should be important, and sometimes the tension of the wound borders are high, and the descents, the rate of descents is increasing.
Thank you. So our last question. So Sara, I'll come to you, and I can add to this as well. Actually, where can I find out more about the undisturbed wound healing concept?
So there are a number of papers about this concept, and if you navigate the world of wound healing, you'll find a lot about this. I think the problem is that this subject, the incision care, is often dealt by surgeons and nurses from the surgical world, and not from the wound healing teams. And when you combine like a surgeon like me or Daniel with someone that has interest in wound healing, it's really interesting in my opinion that you can bring a lot of concepts from the world of wound healing that should be inside the world of surgery and incision care. So this is what we are trying to do, bring the concepts that we know from wound healing into the surgery field. And if you search a little bit, you'll find a lot about this. And I know that Ed mentioned that you will have like the links for the education sites. You'll find more information about that there, and that's the way, I promise.
Thank you.
I would like to add that before being a surgeon, I was a nurse, so I have experience in chronic wounds as a nurse. And what we are doing with the surgical wound is the same that we did before with the chronic wound. Understood wound healing, moist environment, isolate the wound for external agents. It's same concept of chronic wounds, but extrapolated to a surgical wound.
Fantastic, guys. Thank you both. As they both said, I know Lindsay kindly put up some links earlier, so those links will be in the chat function, but also, as I said, when the slides, the video go on our website, we'll make sure that all those links to these resources are available to you. So guys, that ends tonight's event. The link for the certificate of attendance should be up on screen now. Please download that. As I said, that goes towards your CPD and revalidation. So that should be available to you now. A massive thank you from me. To our speakers, first and foremost, to Daniel, to Sara, thank you so much for your time, not just tonight, but all the time you spent on your slides and preparing. So that a huge thank you from me. As always, a big thank you to wound care people, to the team at Möl for your hard work and for staying up late. A massive thank you to Mölnlycke. You guys have supported our business, but also massively support education. So a huge thank you. On that note, next week, on the 29th, we've got a fantastic Facebook Live looking at cavity wounds with Jonathan Boswell, with Professor Alves. So guys, this time next week, please log in. And last but not least, a big thank you to all you guys for joining us. You continue to humble and inspire everyone in our team. So have a fantastic evening. Stay safe, stay strong, and we look forward to seeing you very soon. Thank you so much.
Thank you. A pleasure.
Bye.